mentioned last time, my appreciation, hopefully this is important enough that you want to be here, but after listening to Dr. West speak this morning, anyone who skipped one of his sessions to come listen to somebody else, that's pretty meaningful. So thanks to you guys. And we're going to do our, Regina, you should come up here. You haven't even finished your
That's okay.
lunch.
I'm good. I'm a mom, that's what I do. Oh, hi. Welcome. No, I was going to say, can you take the camera out of here, please?
So I will let Regina and I are tag teaming today, and I'll let Regina introduce herself when she steps up. But I am Matt Strittmater from the Crosse County Human Services. And so today what we hope that we give you a good sense of by the time you leave today is really the services and supports that we have available through the Crosse County Human Services. A disclaimer that I do need to mention is I won't be able to represent all the different things that the community has to offer. Really what I'll be able to do today is talk about human services, the treatment services we have, especially for mental health and substance abuse. If you were hoping to get more flavor of what the community has, if you don't already know, 211 is an amazing source of information for children, families, adults, but especially in that children and family, whether each of us knew it or not, they have just layers of information. Different, obviously location, hours, payer sources, age ranges that people are comfortable working with. They have a ton of information inside there for any of us as community members or families or professionals. And then since whatever time we have left at the end, we've been doing some things. The county and the school district, historically, we're doing some things today. And I think you'll get a sense from us at the end. We don't even know what we still need to do in the future because obviously more things we need to try to collaborate on and work with in the future. So we'll talk a bit more though about what we're doing together at this time. So what I like to do when I get this started is really talk about the treatment system. The field of mental health is in its infancy, really, compared to many of the other kinds of medical treatments out there. And obviously, you can see that picture. I say not as far back as you can think. These really aren't. Treatment years ago, people thought they were helping by drilling a hole in someone's skull, letting out demons, letting out evil spirits, whatever it is. That was treatment. Removing certain organs, believing that that was the underlying condition to certain kinds of symptoms. Fever instigation, raising somebody's body temperature as a way to try to burn out whatever impurities or whatever it was that might be causing things. Those were treatment. Those were people trying to help not too far in the history. Wisconsin itself, really in that last century, in the 1900s, sleep therapy, as I mentioned last time, and I say this every time I talk about this, I'm a huge fan of sleep. I don't believe most of us do get enough sleep. But sleep by itself was promoted as a way to really overcome a tremendous amount of mental health challenges. Focal infection, very fancy name in Wisconsin. Someone got a Nobel Prize or something in the world of science for this theory that a lot of the significant delusional thinking, things like that was really related to dental health and to rotten teeth and such. Now, today we know that dental hygiene, dental health is a huge piece of how well someone might be doing and can definitely make things worse, but by itself is not an underlying cause of mental illness. Psychic stimulation, again, people thought treatment was injecting carbon dioxide into the bloodstream to change body chemistry as a way to help someone. Those are the 1900s, which isn't that long ago. Somewhere in those 1950s or so, one of these days somebody's going to call me out because this is my brain going back to what I remember. But psychiatric medications, the things that are pretty helpful today, I believe started from medication for, I think it was blood pressure. And seeing that that made a difference with some people, which has led to trying other things and tweaking other things. But that whole world of medicine, roughly in those 50s or so, 50s, 60s, as a tool was obviously really valuable, really helpful, helped lead to deinstitutionalization, and not to come across as a teacher or such, but again, it was thought that really good care was removing someone from society. Let's find a quieter place, a place to remove from stress, from all the different things that are going on. Let's give them a safe and humane place to be. That's how institutions started. Institutions became the picture you see on the side where people are warehoused, horrible conditions, just terrible situations. But they didn't start that way. With medications and with other advances was really, hopefully what we're doing today is this community-based care. And community-based care isn't the county system. It isn't, we're a piece of it. But it isn't our program. It isn't Gunderson. It isn't Mayo. It isn't private providers. It is the school. It is the county. It is a neighborhood. It might be the new neighborhood initiative thing that we're starting. It's today's conference. It's really just all those pieces. Services are part of it, but really the overall community approach. That's where we've been for a while, but we're really just sort of, I think, getting to the stage where we're having some of the meaningful collaborations and putting some of the pieces together. So an evolution, which, obviously I went back over 100 years, but it's one of the last areas of how to be effective. A lot of changes occurred in this past century. So really what I'm going to talk about first is the county service system. And there are, I want to make sure I highlight this well, there's 3 brochures here today. One of them might be helpful if you're in the school system. One of the brochures is our crisis system, put a specific brochure for the school system on when should you call us. There was lots of just kind of confusion, how to best support each other. We have a different mobile crisis brochure I didn't bring today for the general community. There's a specific one there for school system personnel. There's a specific program about one 3-lettered program that I'll talk about today at the county. It's really exciting because it's the first time I think ever a county system has been able to say if more people need this service, because it's 100% state funded, we're able to grow the service to meet whatever the community need might be. So I brought a specific brochure for that. And then the basic thing that hopefully you can walk away with today when it comes to the county system, there's a 1-page description trying to show you our 3 main platforms for mental health and substance abuse services for children. And it's a bit about, what's the name of it, who's eligible, is there a cost, how do you get referred, a little bit of flavor about the program, but all of it on 1 page. And I'll be talking about that today, but if you can walk away with that, I think you'll have what you need. Another thing I want to say about the county system, and I know this sounds a bit like an administrator, but we have a finite amount of resources, most of which is based off of county taxpayer levy, some state dollars, and some revenue that we can bring from billing like medical assistance. The finite piece of that means we have to really have a vision and a strategy for what is it that we want to do with our services. And so what we don't do is try to do the same thing if Gunderson is trying to do something, or Mayo. If there's a system that's trying to meet that need already, there's so many holes, so much unmet need that we don't try to compete with what's out there. So the county system is, for the most part, really geared toward the individuals, the children with a really significant mental health and substance abuse. Probably individuals that are a level of the disability, they're able to get medical assistance. There's a lot of kids that fit that category. And if the service that's going to serve them decently isn't brick and mortar where they can go to it, that's what most of the rest of the community is able to do, office-based settings. So most of the services I'll talk about is we send services out into the community, and it's mostly for those individuals with medical assistance that are on the deepest end of the needs. And then our crisis system, which I'll talk about, because although people do pieces of what a community needs for crisis response, we try to have a continuum available because it's needed and it doesn't compete with other pieces of the system. So we really have the 3 main platforms of our services, and again, they are referenced on the handout, and I'll talk through each one of them today. We have our mobile crisis program. This is a 24-hour, 7-day-a-week service. It is a telephone, and it's also face-to-face, and even though this isn't another little piece of it, it will go wherever the service is needed. There are days and times we go to the school systems, we might go to a family's home, we might go into a hospital system, we might go to an emergency room, we might go to a library. There was, a couple years ago, there was a terrible accident in Campbellsport, Wisconsin on a weekend. and a few teenagers that were in camel sport and were part of a rollover and SUV and died. And they had a high school dance team here in lacrosse in a competition at the lacrosse center. Well, yeah, right here. And they found out about it, the chaperones found out about it, that this accident happened early in the morning. They were scheduled to compete that day, and so they didn't know what to do, so they called the county crisis line. There is no way that we train people to debrief and work through 30 or 50 people, but they are trained to just sort of be there for whatever might come up. And I think 3 or 4 of them came that day, brought some other community members, spent about 7 hours just working with that group of people. The most work they did in that day was the bus driver, actually. The bus driver was having high anxiety just about the fact of driving everybody back after what they learned. The reason I bring that example up is they don't know. We expect that there's going to be incidents where someone is really struggling with an acute situation because of mental health. They might need to be hospitalized, but maybe we can help come up with another plan. We expect that, and we try to train people for that. But we have all kinds of calls. We might have 3, 4, 5 calls come in at a time. There was a day that I had to take a call as number 7 on the scale. And the first thing I have to say is I'm not currently trained anymore as a responder, but the person, it was a mom, and she just needed to talk to somebody about, she'd had it with their teenagers. And I said, well, I'm not a trained responder, but I have 4 teenagers at home. So actually, I think I can actually talk to you as long as, depending on where the conversation goes. The point with that is that we don't know what. People reach out for any variety of reasons. That's what it's there for. The very intense service through someone doesn't know where else to call and might start with us. A sense of volume with that service, we have about 500 contacts per year for the children and families. We have about 7,000 contacts overall with it when you factor adults in, but about 500 of those are with individuals under age 18, about 300 different kids in 2014 that we served through this program. Cost is a big thing that we need to be very upfront about. If someone has medical assistance, this is a recognized service. There's no cost to the family or the child. But if they don't, this falls into that nasty world of mental health parity. This is supposed to be a cost that any of us who have insurance get it's covered through our insurance. But parity is not as good as it should be. And it's possible that families' insurance will refuse to pay something for a variety of reasons that they find inside subtext this or that. Or someone might not have insurance, and then there is a cost to this service. So all the brochures that we make available, this is a legitimate, highly trained service, and if someone does not have insurance, there is a cost. We have a sliding fee scale. If someone does not have resources, they can end up with 0 cost. But there is a cost that comes. It's not a free service to the community. We would love if it could be a free service to the community, but to have it of the size and continuum of service that it needs to be, it isn't today. The type of services, what I kind of skipped over for a second, the last little box there. We have the telephone, we have the face-to-face, we do some follow-up with families and with kids after a crisis has happened that we're involved with, and we even have some stabilization services, some crisis family homes or some other residential settings that someone can go to for 1, 2, 3 days as an alternative to the hospital, but to be able to get into a different situation, if that would be very helpful for them to stabilize the situation. So that's the world of our mobile crisis system. Last piece, eligibility, it's if something happens. If something happens to someone in La Crosse County, this is something they can draw on. It isn't residency, it isn't if you're a student. There are certainly county services where if you're not a county resident, we're sorry, but we can't help you with that because that's how we're designed. This is not one of those things. Anything happens to anyone of any age in the county of La Crosse, this is something that can be drawn on. 784-HELP is the single number to access any of the treatment services that we have at the county, whether it's the crisis itself and you're looking for the crisis responder, whether it's to reach out and ask about how to get into a program. It's the main number. It is the place that everyone can initiate services with us. The next one is one that is so much fun and it's so exciting to talk about because in the world of counties, and again, I know this is the administrator, but we have X amount of resources. We have to figure out what we're going to do. Sometimes we have wait lists. We try to fill some gaps. And in the end, we can never serve as many people as need service. And in the state of Wisconsin, and this is in response to the Sandy Hook tragedy of a number of years ago, but the governor in Wisconsin, as part of an initiative, put $30 million of additional money into the mental health system. Not reallocated, not drawing from this in order to, it's new money, it's a new investment that has been called by everybody the most significant investment in the public mental health system that Wisconsin has ever had. The main platform for this investment was a 3-letter program called CCS, or Comprehensive Community Services. Anyone, and this is if you're a child or an adult, but this is, like as a county, like everybody else, we have lines, we have service lines, we have lines that are drawn by age or populations, because you have to draw lines somewhere. But in this case, it's a single program that anyone with mental health or substance abuse issues a day-to-day challenge. If they have medical assistance, regardless of the age range, they're eligible for this and at no cost to them. And as a system, the state has fully funded this because it was determined that, and this is true in Wisconsin, literally everywhere, there was insufficient access to public mental health resources. In Wisconsin, the strength of us is we're a local system. We have 72 counties. We can take our local tax dollars. We can decide what makes the most sense to us. The weakness is we're 72 different systems in Wisconsin. We each decide what makes sense. There's no consistency of programs. There's no consistency of what's available. We have our local funding. And in this state initiative crosses over all 272 systems of care, making at no local cost the availability to grow a structure to meet a local need. In La Crosse, we had children waiting sometimes up to 7 years for mental health services. They were getting services in the community. They had medical assistance. They would have a prescriber or a therapist, but that wasn't enough. We had some platforms to serve them, but we were full. Now, because of the state investment, we've doubled our social worker force on the children's side, added 8 additional social workers last year, have enrolled 100 additional kids. There's technically no wait period other than someone getting through the door, learning about the program, getting signed up. We assign a staff person. There really isn't a wait. There's no need for someone with medical assistance with mental health or substance abuse of any age. If this program looks like a good fit, there's no local constraint. More exciting about this program is the reason the governor chose this program. If someone's needs are well served by a therapist and like a prescriber, and that works for them, wonderful. But there's all kinds of people that just doesn't work for. It's not enough. And there wasn't anything else. And with this, someone's medical assistance, we form a team that works with the person with their natural supports, hopefully with other providers, to really try to understand what the family, what the child is trying to work for, what's getting in the way, and plug something in. That doesn't sound new. Hopefully that's what everybody's already trying to do. But with this program, we can use our medical assistants to get a whole bunch of things to put in place that are things medical assistants wouldn't do before. They have to make sense, because what I'm about to say sounds like a spa, and it sounds like, as taxpayers, we're wasting money. We can do horse therapy, we can do meditation, yoga, other evidence-based practices in the community, in someone's home that medical assistants won't pay for, martial arts. If there's something that has a very solid, either evidence-based or in that person, a demonstrated ability to make a difference, medical assistance will probably cover it if it's directly related to overcoming a barrier so that child can move forward with their goals. That is totally new with medical assistance. That's what sounds like a spa, being able to get all this stuff. But it's the hope and the belief in the state of Wisconsin is we need to try new things. We need to come up with new approaches to be able to change this dynamic and have less people growing up with more of these issues. So we need to open up access, which the state has done, and try new things, which the state has done. And it's removed the local barrier to that capacity. Inside of that, and I wanted to stress also, so it's mental health or substance abuse. Now, historically, medical assistance is not paid for a lot in the world of substance abuse, but in this program, substance abuse as the main challenge is a reason, if you have medical assistance and that's your main challenge, you can get into the same platform of service, and hopefully we will have things to try. That didn't exist a year ago. There was no program at the county that would try something different or something new. So it's really exciting, and it's something we haven't been able to say for, I don't know, as long as I know, at the county level. Inside that, the last three letters, coordinated services teams. Inside this approach, inside this program, there's an approach called coordinated services teams. This is also being promoted and expanded in Wisconsin. It isn't really new, and this shouldn't sound like this is rocket science. When a lot of these kids with these intense needs, when we know them, they're usually in child protection, they're usually in juvenile justice, they're getting some extra level of intensity at school, they've got treatment. Now there's 2, 3, 4, 5 different places doing their best, trying to work with the family, giving probably slightly different direction. And then in the end, the family isn't successful and the child isn't successful, and we as systems are frustrated because nothing really tried to pull it together where everybody got to the table as often as they had to get together, and they had signed agreements saying that's what they would do to see if it can make a difference. That's a terrible description, but that's the CST program. The school system, the court system, child protection, juvenile justice, if we have a common case and we're going to work in this approach, we'll get together at the table as many times as needed in the course of that first few months to try to give the same direction to the family, hoping that if we can all be on the same page, the family, the child moves forward, and then they don't need all of us around the table later because things are going better and they're driving the process. That's an approach inside the CCS program to really try to see if we can do the best we can. So we have about 100 kids today getting this service. We had about 15 before the state investment. And that didn't mean that the county wasn't putting dollars toward it, but the state investment has made that much of a difference. We were able to add a lot of staff, and I don't know how many more. There should be more kids in it. There's more than 100 kids in the La Crosse area that have medical assistance that the traditional set of services hasn't been enough. So there's more kids we need to be working with, and hopefully as we talk about this more and more, we'll get even bigger.
So they only need to have mental health or substance abuse to be eligible?
Mental health or substance abuse, there's a state screen that tries to take that and prove that it's a day, sort of, for the most part, a day-to-day. It has to be enough of a challenge to think that just going to an office for therapy and seeing a prescriber isn't going to make it. You need something more. So there's a state screen. We don't know the magic answers inside of it, but that state screen clarifies the eligibility. The cost, there's no cost to a family, again, because medical assistance covers that service. And it's for La Crosse County residents, or if you happen to be in the region, La Crosse, Monroe, and Jackson are doing this program as a region. And so that same program I was just talking about, which is brand new in Monroe and Jackson County, we run it as a 3-county system. So anyone in those 3 counties is eligible for it. 74 Help, same way to find out more about it or to get connected for referral. And then I won't talk as long about this one. This is the platform, this is the only platform we've really had before. It was a set of social workers offering something that sounded kind of the same. It's trying to be a wraparound approach, getting teams together, but it served children with severe emotional disturbance or physical disability, developmental disability, autism spectrum, all of those populations. And we had a wait list that obviously if I said somebody waited about 7 years, that's about how long someone might have needed to wait, except in an emergency situation to get service. It is still a piece of our platform, and it can still do some services that the CCS program I just talked about can't, because of course, just like any other system, when there's different programs that come out of different parts of the state, they never have the same rules on what you can do, so sometimes people are in both of these programs to get the best of another one. About 160 kids across all populations are in that. Usually not much of a cost to the family, but there is an assessment of families' resources. A family might have a cost inside of that platform.
And there is a current wait list?
There is a wait list, yep. We were lucky the state invested additional money into that program. There's about $3 million of resources going into that program. And the state increased, found some extra dollars in their system that we could take about 40 more kids off the wait list last year. Expensive services, a lot of those, The program is really designed to help keep really intense individuals out of institutions and whatever it takes to serve someone in a home-based setting. Yeah, definitely a wait for that. But unless somebody gets on the list, they can never get the service. But there is a wait list for it. So at this point, I will turn over to Regina.
Great, thanks, Matt. Does anyone have any questions of Matt? Hey, great. So when Matt was talking about the CST model within CCS, that collaboration and collaborative approach between the folks and bringing the partners to the table, that's what's most exciting and very exciting for us as a school district. And when we found out about the CST model, which isn't really rocket science, it's just bringing the right people to the table, we thought it would be great, and Matt doesn't oversee all of these, but to bring it to all of human services, because I'm sure depending on what group or organization you're a part of, sometimes you wish, oh, I wish we could have everybody at the table and we could all be here for the parent, for the child together, and maybe there's someone missing, and we all want to be together, and that's what this is. A decision isn't made until everybody is at the table. So that's something that we're really excited about. Just a disclaimer before I begin, what I'll share with you today and the little bit of time we have certainly isn't inclusive of all supports that we have within the school district of La Crosse. And you're going to hear a common theme of partnering and collaboration, because we cannot do it alone. You saw in the slides, woefully understaffed and underfunded. These people didn't know I was going to call on them, but Kim Malum in the back row is one of our school nurses. And I think the suggested ratio, whatever population for school nursing, is about 1 to 250, 500. And we have school nurses with an average of 1,000 or more. Well, more than that. We have 5 nurses for over 6,000 children. So, in terms of following the school nursing guidelines, and ideally each nurse would know every student, every family, every, all of those pieces, all of mental health practitioners. We cannot do that with the staff that we have, and that's why collaboration is so important. Whether it be with county nurses, with other organizations. This morning we had Gunderson Mayo, county mental health, there are probably 7, 8 organizations here. And I'm glad that you are here, because that would be the theme for my portion of the presentation, is we just can't do it alone with what we have. We have another counselor here, Mr. Rick Blazing, who some of you may know, and he's in that same situation as a counselor at a middle school, and trying to meet the social, emotional, behavioral, and financial support needs of all the students is difficult. So what do we do to work within our school system? I'm just going to sit down here. For the needs of the children and families. Oh, how did I do that?
I don't know.
That's new. I didn't do that last time. So within the school district, you may have heard, if you've worked with us in any capacity, that whether it be for academics, behavioral support, mental health support, we have a 3-tiered approach to supporting students. And the behavioral model of that is called positive behavior interventions and supports, which we'll talk about in a moment. The instructional academic piece is, maybe you've heard of it as RTI, response to intervention. And what that is when we look at a school, when we look at students in an individual classroom, we know that a teacher using sound practices and approaches and making relationships with each and every one of the students. So if it's an ideal situation, 80 to 90 of the students will learn in that setting. So 89 to 90% of the students will be able to retain the information, understand what is being taught if it's a reading class, and with whatever format that is presented in. Then at the tier 2, the selected group, about 5 to 10% of the students in that class aren't going to understand it the first time it is presented. So again, using this example of a reading teacher, they're not going to understand just the way that the rest of the class is learning, and they're going to need either a different approach to the material, or they are going to need to have a different staff member, a different individual come in, teach it, different person, different strategies in order for that child to be successful with that reading. And then for the target or individualized instruction, 1 to 5% of children, neither of those first two things will work. Maybe they were in small groups, that didn't work. They really need individualized supports and interventions. And that's where a lot of you work with our students too, for those one-to-one times when children need help in the area of mental health or within their group or organization, things that they are not getting here at the school system. So for that three-tiered approach, you'll often see a pyramid. I don't know, in the field of education we use triangles and pyramids a lot to represent various things. This happens to be the typical model for tiers 1, 2, and 3, and you'll see that in the next slides. So when we talk about supporting the mental health and well-being of the students, again, I believe Dr. West referred to this and probably in other presentations you've been a part of today. It's all about the relationships. And when you were in school, I don't know, I know when I was in school, there were some folks you had a great relationship with, a great connection. May have been your favorite teacher, perhaps wasn't, but it was really easy to talk to that person, to learn from that person, to communicate with that person. And you probably opened up your mind and you learned a lot more. Well, what we see in the area of mental health and well-being for kids is the same holds true for those personal relationships. When you know someone and care about someone and feel connected to someone, you're going to be much healthier as a child and do a lot better in the school setting. So it's not possible for us as a school district to say, well, the academics are going to be here and the social, emotional, mental health is going to be here, and we're not going to try to touch both of those. And we need to do a better job. That's why we're here learning from all of you and having these conversations of meeting all of these levels of mental health at the universal, selected, and targeted level. So universally, what do students have in the school district of La Crosse? Again, not being all-inclusive, but we'd be looking at the building-wide and classroom staff and settings for students. So some things they have, for example, at the elementary level, they have classroom guidance, where they have conversations with the classroom teacher and the guidance teacher, which is either a counselor or social worker in our district, about empathy and compassion. May talk about some specific issues like good touch, bad touch. Talk about ways to advocate for yourself and things with positive supports for your family or where to go if you need help, things such as that. And each class, ideally, according to the counseling model, they would have classroom guidance once a week. With our staff, we're able to provide that twice a quarter. So each of our students gets a classroom guidance lesson twice a quarter with a classroom counselor or social worker, and then of course many conversations outside of that as well. Then our families, community and county partners such as MAT, mental health liaisons, parents and teachers as allies through NAMI, the National Association of Mental Illness. They have come in and done presentations for us, worked with us, so that we can improve the way that we work with students. Most of our children do well and are healthy and function well within the school system, and we are able to serve their needs. I would say that Dr. West's slide, as well as Dr. McCoy's, about the population we are not serving, even taking race out of the picture, but a lot of our socioeconomically disadvantaged youth, we want to work together and find a way to do a better job with that, because we are missing students, and that's why we cannot do it alone. And that's often who we find in that upper tier 2 and tier 3 is the marginalized youth. So that's when we bring in some of our selected services. They get all of the things above, plus you're going to see those students having more direct contact with their administrators, counselors, social workers, pupil services staff such as Rick and Kim, and special education staff, health and human services. These are families who often are asking for supports from the schools, or the children are not able to function in the regular school system. We have a very high rate of suicide in this part of the country, in the Midwest, and it's certainly not specific to other parts of the country. We have a very high suicide rate here in La Crosse. And starting with children when they are young and building those relationships and having good connections through the community and the schools is where we need to begin. And then targeted for that 1 to 5% of students who are still struggling, we need to do more. So they get all of those services, and then they also have support from individual counselors, intensive therapy. Some of that is offered on site, which I'll talk about in a moment, but the majority of that is done in special settings, perhaps in some of your workplaces or offices, as we work with partners to address the mental health needs of students. So in terms of a safe and supportive learning environment, each one of our schools in the school district of La Crosse has some form of positive behavior interventions and support structure in their school. It looks different in every single school, but basically it's founded on the model of having rules and expectations that are taught to all the students and staff, and that doesn't sound very glorious and exciting, but what we find is that when we just assume that a family, that a child knows the rules of whatever it is that we're referring to, the kids suffer because they really don't know. I assume Matt should know that he should keep his mouth quiet in his seat and walk in a straight line and do what I tell him to do, right? That's what you do when you're a child and you're in kindergarten. What do you mean he doesn't know how to do it? Well, maybe Matt's never been in a structured setting before. Maybe he never went to daycare. Maybe his mom works 3 jobs and he's been with grandma down the street and he's never learned how to do that. So it's our job and our goal that we go ahead and teach and reteach those expectations and then reward them with positive reinforcement. And again, it looks different in each school. When we're working with preschool students, it may look like what I call sometimes trinkets and tokens and ways to reinforce that behavior, create that positive environment. And as we move up through elementary, having that positive reinforcement isn't necessarily a thing. You move more intrinsically to that reward. Middle school and high school, it looks even different, even more different from the elementary. Maybe there are more large group events, and I know Rick at Lincoln, you do your what's it called pause assembly and support the students academically, behaviorally, and social emotionally in that setting. So that would be kind of the gist of positive behavior intervention and supports. And then when we're looking at those kiddos up at the top of the pyramid, their individual support might be having individual contact with families, having some support meetings for parents, doing a functional behavior assessment that basically, and I apologize if I'm saying things that you're already familiar with, but an FBA is something that tries to find the focus, the reason for the behavior, and then we as a staff can work to address that and try to fill whatever that void or need is for the student. So that would be the universal selected and targeted or individualized supports. So something that we do in the school district of La Crosse in a number of schools is we have mental health liaisons. And this is really exciting for me because this is completely voluntary. These are folks in the community whom we've gone to and asked if they'd be willing to be a partner with a school team. And they have agreed and freely give of their time. There's no financial or physical compensation, and actually when they come to volunteer in our schools, we have the requirement that they don't go seeking additional students to be a part of their caseload. What we hear from most of our mental health providers is we're not looking for business, we have plenty of our own. But what we did, this started in just a few schools, and now we have mental health liaisons in in all but 3 or 4 of our schools, I believe, elementaries. Often there's a principal who will say, I have a need here. We have so many student needs. Parents are asking for resources that I'm not sure about how to guide the folks in the right direction. Not sure if this child needs a mental health referral or if they just need supports in a different way. Teachers are saying we're not quite sure if we should be suggesting mental health support or going to the pediatrician. You talk to the nurse, the counselor, social worker, the teacher, the administrator, faith-based cultural organizations, and we're just not sure. So then we can call for free or contact or have a meeting with our mental health liaisons, and they will help guide us and assist us in that process. And, you know, we have counselors and social workers on site, but due to staffing, they're not able to focus just on mental health needs of students. An example is at Hamilton Elementary School here in Crosse. It's one of our smallest elementaries. Actually, it is our smallest elementary right now. But they have a lot of high needs within the family, and they only have a half-time social worker in that whole building, not a counselor, a half-time social worker. And right now, school is in session in the summer, and they don't have a social worker there. So we have to work together to try to meet those needs. So our mental health liaisons are typically therapists. We have therapists from the county, from the hospitals, private and community-based therapists. We also have UWL, or higher ed. There's a gentleman from the psychology department, school psychology, who that's kind of his passion, is working with children in mental health. And they offer their time. We typically ask for a commitment of 10 minutes to an hour a month. And some of ours do way more than that, maybe 10 hours a month. And sometimes we have times when they're not meeting at all. But they partner with our staff and parents, and it's an adult-based support. So it's trying to work with staff to understand mental health, to understand ways that we can better address those needs within the school. And there's no direct contact with the children. There's one exception with that at a high school level, where one of our liaisons works with some small groups of adolescent youth, and that was the children's request of her. So what are some of the activities that we do? We have a mental health team, and some of our liaisons are a part of that, as well as administrators and staff support, who meet monthly to talk about mental health and ways that we can improve the systems of mental health within our district. We've conducted needs assessments, so if I were to be with Matt, I would come, and I'm a mental health support specialist, and I ask him if I can talk to his staff, and we'll survey the staff to see what is it that you need. Do you need to know how to talk to families about mental health when you're at conferences? Do you need to know more about depression and signs of depression in youth? Are there cultural barriers that you're not comfortable talking about, and you're not sure if what you're seeing is a mental health issue or a behavioral issue or something else altogether? We do staff development, so our mental health liaisons have conducted staff development throughout our district on things like personality disorders, depression, overextended youth. We had a lot of that in a number of our schools over the past years. Just, you know, these kids are doing everything, sometimes hardly have time for their homework, and more and more and more, and what does that mean on the well-being of a child, or the parents for that matter. And then again, navigating the mental health system, the ACEs, response to intervention, all of those types of things. Offering expertise at staffings or meetings. So sometimes we'll have a group, it could be a CST type model, but where we're problem solving with a child. Sometimes there's a parent there, sometimes it's just a teacher trying to get some supports. And we can, not using names, it has to be completely confidential, but we can say, boy, I've been wondering about this, here's a case study of a child, is there something we're missing? What do you recommend? And they offer that to us. And troubleshooting problematic situations, and then parent training and support. And I will have to give a shout out to Gunderson. Looks like there's at least a couple staff members here. They have come through so many times through various initiatives that are going on through the Gunderson Health System to support parent training. Parents will ask, have a topic that they want to learn more about, and completely free of charge. And I guess I'm highlighting this, and Matt might talk a little more later, because this isn't typical when I talk to my contemporaries and colleagues around the state. You know, there are folks who say, you can get the hospital to come in and talk about whatever, diabetes prevention or whatever it is, and boy, we have to pay them $150 an hour if we wish to work with them, or And for us to have, I'm seeing different organizations, our Stepping Stones, Hope Academy Family Children's Center, our friends from the Ho Chunk, and I'm sorry, I don't know. Oh, Lacrosse County, well, you have to be here, Val, right? Yeah. But all of these organizations at Barnes & Noble, who gives us thousands of books, over the past 3 years, who are doing these things free and because they want to make the lacrosse community better. I think we take that for granted, and it isn't that way anywhere. And we're to the point where we're insisting on more and better collaboration, and folks are looking at us and saying, how are you even in a room together and you can have the time and have this conversation? So I think that's something to be happy about in terms of our community. Okay, so then. And then in terms of our community partners, and I'll just highlight those quickly. Of course, we work with our county, city, and civic institutions. Maybe institutions is too strong. Organizations and partners. Our health systems and our hospital. That's where many of our mental health liaisons come from, ongoing consultation with staff. Our adolescent and behavioral health, Gunderson's hit-free zone. Some schools have taken that on as their own and talking about what is a safe setting for children and youth. And then various training on ACEs, trauma-informed care, that kind of thing that I've spoken about. Our private and public therapists and counselors, again, a number of them are mental health liaisons, and we do offer one-to-one site-based therapy where students could have their individual counseling on site in some situations. So it's not our go-to, but if you are a therapist and you have a child who has a need and the parents say the only way they could have counseling is if it were at school, and as a parent, as a staff, as a therapist, you think that would be a good thing for the child, and if the building has space available, it is possible to have therapy right in the school setting. And that's fairly new to us just within the last couple years. Our community cultural and faith-based organizations, they offer things like after-school tutoring and support, counseling, meals, training, clothing. And I wanted to highlight the acceptance and welcome. Sometimes we hear from our families that that's the only place that their child feels safe. The only place that their child feels welcome is when they are at their church, or that's when they feel the best, when they're at their church or with their cultural group. And so we need to find a way to mirror that in our school setting, and our PBIS and other initiatives are ways to begin that. Also, our higher learning institutions, Mayo, Gunderson, Western, have been just so instrumental in supporting us and supporting our efforts for mental health within our schools. And I underlined, because I think it's so important, they train our future educators and advocates. So, in 30 years from now, in this room, it's going to be a whole different batch of folks, hopefully not talking about the same issues, but they're going to be the ones who are working with our youth and our families, and our higher learning institutions are so integral in that. And then also our nonprofit organizations, I just highlighted 4 here. Our Boys and Girls Club, they offer a lot of leadership in the area of mental health within the community. Their kindness campaign has been just fabulous with kids. They're talking about it in their schools when they come back. The YMCA has a teen center in which a mental health therapist is directly on site and available for students. The TSPN, which is the Teen Service Providers Network, and if you work with teens and you aren't aware of that, talk to me after, because it's a great place to network with other folks who are serving youth and making a difference in the community. The La Crosse Community Foundation has grants, dental health for students. It supports mental health for students. We have $500 scholarships, which isn't a lot, but to get an assessment started for mental health. They have special grants and projects. For us, the St. Clair Health Mission and Family Neighborhood Clinic offering free or affordable health care. Again, these are not all encompassing, but just a few highlights. And then quickly, in the time we have, how are we working together as a county and school district? Well, this effort began with the mayor and the superintendent and the county administrator. And so just bringing folks together, again, it's something I take for granted. But having that on a purposeful basis, I don't know about you, today isn't the big day in my book for Rebuilding for Learning. It's the networking and the connections that I've made here and getting to know other people for doing the important work when you get back to the office. The Family Policy Board.
Yeah, Family Policy Board is part of La Crosse County government, and the school system is an active participant to help lead that and participate in various subgroups. One of the subgroups is a mental health substance abuse subcommittee. And just an example of a couple of things that's worked on is in the last couple of years it was charged to try to help with family navigation. It's, you know, those of us who work in the field or close to the field, we sort of know what's out there for resources, and we still learn something new or are surprised. Families don't know where to start, and they don't know who to call or where to call, or even if they know their insurance, they still don't know. And even if they know their insurance, what's different and who does what and who's good at what and who's trained to be able to handle things. So we heard that loudly from families, and so started looking into that, and that's where we learned, you know, those of us who are already in the field who knew about 211 learned exactly how much depth of information 211 had available. So one of the things we want to be doing this next year is trying to help the community understand that, because that could be family navigation, or any of us. All the resources are there, it's free, it's anonymous. If you're amazing on a website, you can navigate through their system yourself. If you're not, or if you think you are and you get stymied on their website, they're available and they can talk you through that. So that's, you know, we want to work on promoting that, and then we're also working on exploring a screening tool for that to promote in the community. There's going to be some tools like ACEs that hopefully grows, the number of us that use that, and how we use that and talk that common language. But there's also probably the need for other tools if you're not sure if mental health or substance abuse is a piece of what you're seeing today and you're a non-clinician, you know, is there a simple tool to get a sense that, yes, it looks like it's that, and from what I learned today, here's what I should do next. That seems to be another missing piece in the community. So we're trying to look, there are some community efforts trying to promote tools like that to get us all on the same page, feeling comfortable and really helping the communication and how we take steps forward. So examples of a couple things inside the Family Policy Board. CST, I think we've talked about, so I won't spend much more time other than we said it isn't rocket science, but it's trying to force us all to do what we all want to do and say we want to do through the MOUs and getting it all on paper, clarifying the expectations, how exactly, how often are we going to meet, why are we meeting that often, are we committing to be there, making that a little extra formal so that on a certain number of cases, even though we want to do it everywhere, can we really do it well in a certain number of cases is a way over brief explanation of that whole program, and we'll see if we can make a difference.
And then I spoke about the school mental health liaisons already, and the school mental health collaborative meetings that take place as a result of those collaborations. And then the juvenile justice and disproportionality. And I told Matt I thought I was going to get to go see Dr. West for this session because I thought, oh, I bet everybody between Dr. West and disproportionality will go there and we won't have anyone show up and then I'll be able to watch Dr. West. But the juvenile justice and disproportionality is something that we really have an eye on, and we're working with the community. It's certainly not specific to the school district, to the to the county, but the resources are there to look into the issue. We've recently learned some of the data that we originally thought was leading us one way is no longer leading us that way, so looking at that whole effort again and what that means, but doing a better job within schools, within community organizations to serve our youth. And then future collaboration that we're probably not even thinking about. And this is just collaboration here with the county. Matt could have a whole nother conversation, you know, in another presentation, I'm sure the county to another organization or, but those are some of the things that we do together. And in full disclosure, I asked to be a part of this, to hijack your presentation a little bit, and you were so gracious in allowing me to join you, so thank you, Matt, because I learn from you every time that I come here, and it's really, to me, the theme about working together.
Yeah, and even though, you know, we learned, I don't know, in the last couple of weeks, we were on a common phone call with someone at the state, and you heard, I think Regina said earlier today, you know, sharing what was on the back of that blue-sided piece of paper about what was going inside of a school system manual. Part of the reason it's going inside that toolkit is because in many communities, schools in the counties, they don't talk to each other. They don't answer each other for whatever the reason. And they're good people, but they don't. I mean, you could get stuck on the opposite ends of situations that are tough and they're hot. And for whatever reason, even though we don't have things figured out here, we seem to have the right spirit, and we're sitting around the table and part of bigger tables with other people just to see whatever we can do. Apparently, that's more rare than we thought it was.
Yeah.
And so that's a positive sign for the community.
In the first group, I did ask, and I know we're over by 5 minutes, and I want to honor your time, but are any of you within a school system or besides you with La Crosse County? Okay, and then how many of you work with nonprofits? Okay, and then how many are faith-based organizations, cultural organizations within the community? Okay, and then businesses, private businesses, I guess that would be you. So I just thank you for your time. We'll stay after for questions, but I want you to go ahead and feel free to leave. I know some people had some things going on after, but please come. I know Matt and I might be the chip while we chat, but I'd love to talk to you if you have other thoughts or ideas or questions. Apologize for going over by a few minutes. Thank you for your time.